Happy New Year, everyone, and welcome to Season 4 of OsteoBites. My name is Christina Iptoma, and I am mom to OsteoAngel Dylan and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are talking with Dr. Marie Nelson, Assistant Professor of Pediatrics at Children's National Hospital, about an open Phase 2 trial combining cryoablation and immune checkpoint inhibitors in pediatric solid tumors. Thank you so much, Dr. Nelson, for joining us on OsteoBites today. We're thrilled to have you. And thank you to Walker Smallwood for joining us as panelists today. Walker is an osteo warrior, and also we're lucky to have him as an MIB Agents Junior Advisory Board member. A little bit more about our guest today. Dr. Marie Nelson is originally from Michigan, and she attended college at the University of Notre Dame and earned her medical degree from Loyola University Chicago Stritch School of Medicine. She finished her residency in pediatrics at Anne and Robert H. Lurie Children's Hospital of Chicago prior to completing a fellowship in pediatric hematology, oncology, and bone marrow transplantation at Children's National Hospital in Washington, D.C. Dr. Nelson is a member of the solid tumor faculty and assistant professor of pediatrics at Children's National Hospital, where she also leads the adolescent and young adult oncology program. And her research focuses on combining local therapies and immunotherapy in order to improve the outcomes and reduce the side effects of treatment for pediatric patients with solid tumors. And she's the principal investigator of a Phase 2 trial, Neoadjuvant dual checkpoint inhibition and cryoablation in relapsed refractory pediatric solid tumors that we're going to be talking about with her today. So welcome to everyone joining us today. Please feel free to add your questions for Dr. Nelson to the Q&A. And Dr. Nelson, thank you so much for kicking off Season 4 of OsteoBites with us. We can't believe we're in our 4th season. We've produced nearly 90 episodes, if you can believe it. So we have quite a large archive now of presentations on research studies and navigating surgical and treatment options. So be sure to check out our YouTube playlists. Before we get started, just have a few announcements. Even though it's the start of the year, we have so many things going on. We just announced our dates for our Factor Osteosarcoma Conference. It's going to be June 22nd to 24th in Atlanta, Georgia. And registration will open next month, and I will put a link in the chat with some more info. We are now accepting abstracts for the conference. The deadline is February 24th, and I'll also pop a link in the chat about that. And then we have our research grant program, Outsmarting Osteosarcoma. Grant applications are due February 3rd, so about 4 weeks away. We have a $100,000 annual grant and a $50,000 annual grant for young investigators. And like last year, we expect to fund multiple awards this year. You can apply online at Proposal Central, and I'll put some more information in the chat about that as well. And lastly, to stay on top of all these programs and events, subscribe to our monthly newsletter called Connective Issue. It includes info of interest to our osteo community, including recent news and papers, open clinical trials, job postings, info about all our upcoming events and programs, and also spotlights on members of our community. We actually recently had a spotlight on Walker and his really incredible story. So to make sure you get all this delivered in your inbox every month, just go to our website, click on the Join Our Community form, and I will also pop that link in the chat. Great, so that's enough for me. Walker, would you please introduce yourself?
My name is Walker Smallwood. I'm part of the Junior Advisory Board this year. I'm an osteo warrior, and I'm just really excited to be here today.
Fantastic. And Dr. Nelson, we'll hand it over to you to go ahead and get started.
Good afternoon, everyone. Thank you so much to MIB Agents, to Christina and Walker for having me today and giving me the opportunity to discuss a recently opened Phase 2 trial at Children's National in Washington, D.C. As a pediatric oncologist, I am so blessed to have the chance to work with amazing patients and their families who inspire me every day as we work together to find more effective and better tolerated treatments. So I dedicate this project and presentation to them. Today, we will start by reviewing the current status of treatment for pediatric solid tumors and why the activity of immune checkpoint inhibitors is limited in these cancers, including osteosarcoma. I will review cryoablation therapy and how it can enhance the efficacy of checkpoint inhibitors in solid tumors. And I will end by discussing our newly opened and innovative phase 2 trial, which combines immune checkpoint inhibition and cryoablation therapy with the goal of inducing a response in pediatric solid tumors that is not seen with checkpoint inhibitors alone. Pediatric solid tumors are a heterogeneous group of aggressive tumors of the bone, soft tissue, and other organs, which are treated utilizing a multimodal approach with surgery, chemotherapy, and sometimes radiation therapy. Unfortunately, our upfront or gold standard treatments have not changed in decades. Patients with metastatic or recurrent disease are at risk for poor outcomes because of lack of other effective treatments for them. Survivors are at risk for significant long-term effects due to the toxicities of treatment, including cardiac and renal dysfunction, infertility, and second cancers. Therefore, we really do need new and effective treatments for these patients. Immune checkpoint inhibitors are monoclonal antibodies that target proteins called checkpoints on tumor cells and patients' white blood cells. By blocking these checkpoints, specific white blood cells called T cells are stimulated to attack cancer cells the way they would a cold or the flu. These agents, such as nivolumab and ipilimumab, have led to breakthroughs in select adult cancers, such as melanoma and lung cancer, but responses have been limited in pediatric tumors when they're used alone. Evidence has shown that high-risk pediatric tumors, such as sarcomas, like osteosarcoma, have cold tumor immune microenvironments, meaning that they do not express antigens such as HLA and have low levels of T cells called tumor-infiltrating lymphocytes that are needed to have a response to immune checkpoint inhibitors. Osteosarcoma has been generally found to have low levels of CD8 positive T cells and HLA antigen expression, and higher levels of these things have been found to correlate with a good response to chemotherapy and a favorable outcome. This slide depicts the many pathways that play a role in osteosarcoma's immune tumor microenvironment, either leading to a pro-tumor response and enabling tumor growth and a progression, or leading to an anti-tumor response and preventing tumor growth. This slide also highlights potential ways we could use targeted therapies to incite a response against the tumor by, number one, increasing specific types of immune cells, such as T cells, B cells, and natural killer cells or NK cells. And number two, blocking immune checkpoints present on these T cells, such as PD-1 and CTLA-4, to augment an anti-tumor response. This slide displays how checkpoint inhibitors work. As discussed, checkpoint proteins are expressed on both T cells and tumor cells. Tumor cells, like osteosarcoma, can express the checkpoint protein PD-L1, which interacts with PD-1 on T cells. This interaction turns off the T cell, preventing the immune system from recognizing the tumor cell and protecting the tumor from the immune system. In a similar way, another checkpoint protein called CTLA-4, which is expressed on T cells, as you can see, interacts with antigen-presenting cells, and again, turns off the T cell response. Checkpoint inhibitors block the checkpoint protein, so it cannot bind with its partner protein. Therefore, the T cells are not turned off and can recognize the tumor cells as a problem for the immune system, stimulating an anti-tumor response. As discussed, unfortunately, pediatric tumors like osteosarcoma do not have the needed co-stimulatory proteins or enough T cells present to stimulate an appropriate response to the checkpoint inhibitors when they're used alone. Cryoablation therapy is a safe, local control approach in pediatric tumors of the lung, bone, kidney, and soft tissue. It is used as part of the standard of care in relapsed or refractory solid tumors. As seen in the pictures provided by Dr. Sharma from Interventional Radiology at Children's, using a minimally invasive approach, a probe is inserted into the tumor, and through cycles of freezing and thawing, ice crystals are formed, leading to tumor cell apoptosis, necrosis, and death. Laboratory studies demonstrate that cryoablation creates a favorable immune microenvironment by forming necrotic proteins or dead proteins that stimulate T cells and can potentially enhance the response to immunotherapy. Early results from adult clinical trials looking at melanoma and breast cancer demonstrate safety, stimulation of immune response, and promising objective response rates in both the treated tumor and distant sites. Further, other studies demonstrate that giving checkpoint inhibitors prior to local therapies like radiation, cryoablation therapy, or surgery may even be more effective at stimulating an immune-mediated anti-tumor response.
Hey, Dr. Wilson, I have a question about that on the stimulating response. Like how long is that window? So let's say you have the cryoablation, and then you get all these like dead proteins in there that are stimulating response. How long usually does that last? Do we know?
Yeah, Christina, that is an excellent question, because we don't know how long that response will last for. And so we'll talk a little bit about how the trial is designed. We're not sure. We expect that initial response may last for weeks, but we're hoping with this trial we'll learn a little bit more about, what cryoablation is able to do to the immune response within the patient, and how long that response may last for.
Great, thanks.
And so we hypothesize that the cryoablation therapy of tumor tissue will enhance the systemic anti-tumor response to dual checkpoint inhibition with nivolumab and ipilimumab, so checkpoint inhibitors, in patients with pediatric solid tumors due to an augmented T cell activity within the tumor. We also hypothesize that the cryoablation therapy, despite being a local therapy, will cause a stimulation of the patient's immune response within the tumor and intensify an immune response elsewhere within the body, leading to improved disease control at all disease sites, or something called an abscopal effect, and that the combination of cryoablation and immune checkpoint inhibition will be well tolerated by patients. We are excited to now have an open phase 2 trial employing 2 checkpoint inhibitors, once again called nivolumab and ipilimumab, with cryoablation therapy in relapsed and refractory solid tumors. When we think about clinical trial phases, a phase 1 trial, the goal is to assess which dose of the medication is tolerable and safe for patients, and to better understand how the drug works in a patient's body. A phase 2 study like this has the main goal of assessing, does this treatment work? So the primary objective of this study is to assess the disease control of nivolumab or anti-PD-1 and ipilimumab or anti-CTLA-4 when given prior to and following cryoablation therapy at the pediatric recommended phase 2 dosing in patients with relapsed or refractory pediatric solid tumors, namely osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma. The secondary objective is to confirm the safety and toxicity profile of immune checkpoint inhibition in combination with cryoablation therapy in these patients when it's administered on day 1, followed by the cryoablation therapy to 1 target lesion prior to day 15 of cycle 1 only. And then the exploratory objectives are to assess distant anti-tumor effects of this combination in a kind of rare tumor arm as a non-statistical cohort, to explore changes in immunogenicity and predictive biomarkers of response to this combination in blood and tumor tissue through tumor sampling at the time of cryoablation therapy. And then lastly, to explore changes in patient-reported quality of life outcomes using the PROMIS Pediatric Scale and the PROMIS Parent Proxy Scale. The primary endpoint is objective response rate at distant tumor sites that did not undergo cryoablation therapy, as defined as complete response and partial response per the RECIST criteria. Once again, looking for that abscopal effect that we discussed. Secondary endpoint is to define the toxicities observed when cryoablation therapy is given in combination with the checkpoint inhibitors, and we are using the common terminology criteria for adverse events through the NCI. And then the exploratory endpoints are objective response rate in distant sites in the non-statistical or kind of other tumor cohort that we have. And markers of immunogenicity in the blood and tumor, which are archival or at the time of diagnosis and then collected at the time of cryoablation. Changes in the, once again, the PROMIS patient-recorded outcome scales. In order to be eligible for this study, patients need to be over 1 year of age and less than 40 years and have a refractory or relapsed extracranial solid tumor that has no other curative options. The three statistical cohorts of this study are osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma. There's a fourth cohort for all other tumors. Patients need to at least have 2 tumor sites, and at least 1 tumor site needs to be amenable to cryoablation therapy. Patients who are pregnant or breastfeeding have known CNS metastasis or autoimmune disorders or inadequate organ function are excluded. All patients will receive the current recommended phase 2 dose of nivolumab and ipilimumab on day 1 of cycle 1, and then will undergo cryoablation therapy to 1 target tumor site prior to day 15 of cycle 1. So as Christina, as you were asking, how long are we expecting or hoping to see that stimulated immune response secondary cryoablation? We are not sure, but we want to be able to, based on other studies that have been done, we expect that it should last for a few weeks. And so we really want to try to target the initial response from the immune checkpoint inhibitors that are given, give the cryoablation therapy. Patients will continue to receive cycles of nivolumab and ipilimumab on day 1 of 21-day cycles up through cycle 4, and then nivolumab monotherapy on day 1 and 15 of 28-day cycles onward. They can remain on the therapy as long as they have no signs of progression or unacceptable toxicity. Patients can remain on treatment for up to a year, and we will be monitoring them closely for side effects and changes within the blood and tumor for immune response. This is a look at the trial treatment schema. Patients will undergo an imaging evaluation every 2 cycles, following closely for response. And then peripheral blood will be collected at baseline prior to cryoablation therapy and prior to every odd cycle for flow cytometry to evaluate for changes in the immune cells. We will also evaluate the patient's tumor sample from time of diagnosis and compare it with the optional tumor sample collected at the time of cryoablation therapy and see how things have changed. We are performing immunohistochemistry staining for PD-L1 expression, which has been correlated with a response to checkpoint inhibition, and tumor infiltrating lymphocytes, and the expression of other genes involved in the immune response through an mRNA expression panel.
Dr.
children.
Nelson, sorry, another question. So it sounds like it's basically you get the Nevo and the EP for like up to four cycles, or you can remain on therapy. But the cryo is really just like a one-time thing, right? Because if there's any progression, then you're off study.
Yeah, so
Yeah.
the idea is that we, start the immune checkpoint inhibitors, the Nevo and the Epi, that patients then undergo the cryoablation therapy within that first cycle and just that one time. And then they continue receiving the immunotherapy or the checkpoint inhibitors. Initially it is every 3 weeks or every 21 days. And then starting after cycle 4, the ipilimumab, that second checkpoint inhibitor, kind of falls off, and you just continue the nivolumab alone. And then we continue to monitor the kind of after effects and response to treatment. Our kind of rationale with the cryoablation therapy being one time is that that should stimulate kind of an initial immune response that is then propagated and continued with the continued immune checkpoint inhibitors, that we've changed that tumor immune microenvironment of the tumor, that we bring in those T cells, we increase the antigens, and then the immune system kind of takes over and then is able to continue to target that, not only the tumor that was cryoablated, but also, any other sites of tumor throughout the patient's body.
And are there any size like restrictions, either too small or too big for the cryo? And is there any thought, and I mean, this is probably kind of another thing that's part of the study, but just like, I imagine if I'm thinking like if the tumor is larger, that there's potentially more protein from that, right? So like potential correlation between like ideal size of the tumor and the amount of kind of protein that kind of provides to stimulate the immune response.
Yeah, that's a really, really great question. So, based on our protocol, there's no limit to the size of tumor, but we have kind of set guidelines in, how many probes will be used and how much time will be spent in cryoablating. And while when we think about using cryoablation therapy in, kind of in the palliative setting and, apart from a trial like this, the initial goal with cryoablation was to try to kill as much tumor as possible. And so, that would be the expectation outside of this trial, that you want to kill the tumor cells. But in this setting, we're really just trying to use the cryoablation therapy to our own advantage to stimulate the immune system. And so, and to make that change within the tumor. And so we are not, obviously, if we're able to, to treat an entire tumor with the cryoablation therapy as part of this study, or an entire tumor site, then, I think that is a wonderful thing, and that's great. But we really just want to change enough of the tumor to stimulate that immune response, and then allow the checkpoint inhibitors to do their job.
You may have already covered this, but is there any side effects to cryoablation besides just the surgery itself, or is it like chemo per se?
Yeah, that's a really good question, Walker. So the cryoablation therapy, it's done by the interventional radiologist. So it is a what we call a minimally invasive procedure. So it's done under anesthesia. So patients are sedated by the anesthesiologist for it. That the interventional radiologist is able to use imaging in real time to see where the tumor is. And then they're able to insert their probe that does the freezing and thawing of the tumor. And so they usually will make a very small incision in order to accomplish this. following the procedure, risk to any procedure that's minimally invasive. There's risk for, local bleeding and some local pain associated with it. But overall, we found this to be a pretty well-tolerated procedure. Patients are able to do it in the outpatient setting and go home after. If there are questions I can answer.
Yeah, I think we had a few more questions actually come through the Q&A, and we'll throw out actually some of them now because I think they're kind of on topic now. So one of the questions was, if cryoablation has a positive immunoresponse, can we put forward a thesis that even if we're not able to remove all mets, that they can be affected by this immune response?
So just to make sure I'm answering the question, so please clarify if I'm not. But that's we're expecting, and based on our understanding of the cryoablation plus the checkpoint inhibitors, so that while the cryoablation is local and we're changing only some of the tumor to bring in the immune cells and help it be recognized by the immune system, that the checkpoint inhibitors, they're given into an IV, and so they are traveling everywhere in the patient's body through the bloodstream. And so they, including the tumor that was cryoablated. And so they will stimulate more of an immune response within the tumor that's cryoablated, but then any T cells in the body or other immune cells that are recognizing and seeing that tumor, we know that they're also going to other locations in the body through the bloodstream and visiting those other tumor sites that weren't cryoablated. And so should then have a response, we should see that the immune system is able to target and fight off those tumors as well.
Great, thanks. Well, why don't you go ahead and we'll if you have some additional questions, then we can wait till the end for those.
Okay, perfect.
You want to keep going?
Sure. So Children's National is the leading and coordinating center, and we're in the process of opening the study at Children's Healthcare of Atlanta, Washington University in St. Louis, and the National Cancer Institute in Bethesda, Maryland. We're very excited that this is the result of a collaborative effort of both pediatric oncologists and interventional radiologists. We are mostly thrilled that this trial offers a safe and potentially effective therapy, including a locally targeted and minimally invasive approach for children who currently have no cure for their disease. It will give us the incredible opportunity to learn more about immune checkpoint inhibitors and their activity in pediatric solid tumors, so that we will be able to make them more effective for future patients. I would like to thank other members of the study team, Dr. Aaron Kim, who is my mentor and colleague in the Division of Oncology, Dr. Karun Sharma, who's the leading interventional radiologist on the study team, and Dr. Anthony Sandler, who leads the Tumor Immunology Laboratory, collaborating with us on the correlative studies. The contact information for those interested in learning more about this study is displayed. Anne is the clinical research coordinator, and Sherry is our research nurse assisting with the study. And just want to thank MIB agents again for the opportunity to speak with everyone today. And I'm grateful to our generous supporters who have made this trial possible. And I'm happy to take any and all other questions as well.
Okay, so there's a couple other questions that we got. I think earlier in your presentation you said amendable to cryoablation therapy. So what exactly does that mean?
That's a great question. So the kind of guidelines and what things are able to be cryoablated. So They can be bone tumors. They can be tumors within the lung or liver or elsewhere in the body. The biggest thing is you don't want it any, very close to big vessels or things that could be potentially injured by the cryoablation. So I think that is one of the major things. But otherwise, there are many different tumor sites or places that the tumor can be that the interventional radiologist would be able to treat. And any patient we're referred, we review the imaging closely with radiologists and with the interventional radiology team, to assess which patients are good fits for the study, and which tumor sites would be best to cryoablate.
And then I think you said this earlier, but do you have to have 2 or more tumors to be eligible for the study, or is it just could you just have like 1?
Yeah, so for this study, you need to have 2 in order to be eligible. And that's because one of the aims of the study is to assess the response in a tumor that's not cryoablated, and to watch for a response as well.
I don't think there's any more questions in the chat that I can see.
Great. If anyone else has any questions, please feel free to keep sending them in, and we'll ask Dr. Nelson. And a couple questions on cryo, because I do feel like it's a newer therapy and not all institutions have it available. And I mean, when I've heard of people getting cryo, for osteo at least, it's usually been in unresectable nodules in the lung. I haven't heard of it in the bone, but how common is it in lung versus bone for osteo?
Yeah, so the sites of recurrence for osteosarcoma, or initial presentation most often tends to be in the lung if there's distant sites, but we can see metastasis to other bones or spread to other bones of the body, and so that's something as an oncologist, we always make sure to screen for, upfront, and then over time, patients can be followed for that as well. And yeah, bone tumors. So in the setting of a patient with osteosarcoma that, would be interested in this study, or we were screening, looking, pulmonary lesions definitely can be cryoablated. And then there's also settings that a bone tumor, like an osteosarcoma that spread to another site, could also be ablated as well.
And I think sometimes, like often the conversation can be when you have an unresectable lung nodule, or even potentially like a bone mets that's difficult to get with surgery. The conversation is, usually also radiation therapy, versus like a cryo. And that seems to, I think, kind of still be a little confusing, kind of what the advantages and disadvantages are of radiation therapy versus cryo. So could you maybe kind of help us better understand kind of the considerations, I guess, for kind of what makes something a better candidate for radiation therapy versus cryo, and then maybe what some of the pros and cons would be associated with each?
Sure. So in the setting of treating osteosarcoma, absolutely. So we, chemotherapy upfront, and then osteosarcoma is a tumor that is best served by surgical resection, or removing, when we think about treatment, in addition to chemotherapy, that we need to do something else locally to help treat the tumor or remove the tumor. And the kind of number one option is surgery whenever it's possible. As you mentioned, Christina, depending on the location of disease. So if someone were to have spread or metastasis to other bones, that resecting those areas, especially depending on where that bone is located, can be really, really difficult. And so in settings like that, then our next thought or next step would be thinking about radiation. And this is all, within the upfront setting. The radiation response of osteosarcoma it's just not, unfortunately, just not as sensitive to radiation, and requires pretty high doses of radiation. But in thinking, if we can't perform surgery to resect the tumor completely, that radiation is kind of the next best option in the curative setting for patients. So when we think about kind of other options like cryoablation in settings apart from this trial, that we would think about it more in kind of the palliative setting, that we're not able to resect. It might be a patient that's already been radiated or that's not an option, that we might think about cryoablation as like another kind of third option alone. The goal of this trial is really to help, potentially help patients that have seen all those other upfront options and, are looking for other potential things that may help. And so kind of this combination, while in the past, cryoablation therapy is something that and continues to be an option for patients that have seen other things and are looking for other ways to treat their tumor. This study, I think, offers a different approach that combines a few different treatments, so including the two checkpoint inhibitors or immunotherapy, along with something more local like cryoablation therapy that is something. It's not offered at all institutions or all places, but I think we're starting to see it more and more performed by interventional radiologists in the pediatric setting.
Thank you.
So you said that this is a phase 2 study. So I was just curious on what you think like the time frame would be that this could become kind of a more common and widely used treatment. And then could it ever like rival or kind of become the replacement for MAP therapy at some point?
Yeah, at this point, I don't foresee it becoming MAP therapy, which is something that's been around for a long time, and we at this point haven't found other treatments that are as effective as MAP therapy, or the combination of 3 chemotherapy agents that are kind of the gold standard upfront treatment for osteosarcoma. For these kind of we call them early phase clinical trials that are testing newer treatments. As I've learned, they take a long time to get started, and they unfortunately do take a long time to gather all the results to be able to be established as one of the new standards. And I think there's really been a push, nationally to really get these trials open to be able to analyze data as quickly as we can, because we really want to get these treatments out to patients if they're effective. And so I expect that, the results and, next steps, it may take, year to years, but really trying to push this forward, with an eye on safety for patients, just because we know things can take a while. And I think the other exciting thing about this trial is, as we're treating patients and hopefully providing them some benefit, that we also are trying to learn more about how these medications work, because we're hoping that will provide us better ways to improve how they work in the future and for future trials as well.
So would this therapy overall probably be less or easier on someone's body than just the traditional chemotherapy?
Yeah, and so that's the goal, and that's what we're hoping to find out. These two immune checkpoint inhibitors, Nivo and Ipi, have been studied in other early phase clinical trials in pediatric patients and young adult patients. And kind of our established doses and what we know for the most part should be tolerated and well tolerated and safe, for patients. We are always looking for things that are better tolerated than chemotherapy, but at this point, we know that MAP chemotherapy, while as and many others I'm sure on this webinar are aware of, do have a lot of side effects, but really are the most effective treatment that we know of so far.
And Dr. Nelson, just wanted to, and I know you went through the eligibility, but just wanted to clarify what if there are any washout periods or amount of time that you have to be off other therapies before being able to enroll in the trial. And there also, I know for surgery, I kind of remember there being considerations, there's certain drugs that you have to be off of for, a month before being able to go into the OR, and wondering if there are any of those considerations with cryo, and even also just for starting on the two checkpoint inhibitors.
Sure. So there are very clear criteria set out in the protocol about timeline that patients need to be off certain treatments. So when we think about kind of classic cytotoxic chemotherapy, the cutoff is 21 days. And then there's other kind of guidelines based on other immunotherapy that patients may have received. This does allow patients that have seen either Nivo or Ipi, so other checkpoint inhibitors alone in the past, are still eligible for this study, just because we believe that the cryoablation therapy will add more to the treatment and response. And so there are some washout periods that are in place. They're very similar to kind of what's expected for other on other similar early phase trials.
Cool. And then likewise, is it okay if you've had cryo before without the checkpoint inhibitors?
Yes.
Okay. So as long you can have it either alone, but just as long as you haven't had them in combination, you're good.
Right. Exactly. Okay. And you had a question about surgery as well, and that expect or would.
Yeah, more. I mean, slightly kind of, relevant to the trial, but even more just alone surgery versus cryo, because I know there's certain drugs, I think possibly just because of the impact on bleeding, that you need to be off of for a minimum 30 days prior to surgery. And wondering if there are similar concerns for cryo with the same types of drugs or the same kind of drug class. Is that a concern at all for cryo and the management of?
So there are some targeted medications, not in this study, but in others that do require someone to be off them for a while before being able to undergo a procedure, and so would check on that, or and you'd have to be off off any other study treatments that are apart from this before being enrolled on this study. But we wouldn't expect that the immunotherapy would affect someone's ability to heal. And so there's no kind of clear timeline with that.
Okay, great, thanks.
I have one question. So a lot of times they do osteo research in dogs. So have they done any cryoablation or anything like this treatment in dogs that you know of?
So at this point, cryoablation therapy is it's a standard treatment that's done in adults and in the pediatric setting as well. This combination, is a checkpoint inhibitor plus cryoablation therapy is something that's been done in adults as well. And so I'm kind of past the point of what we call preclinical, which means things that are done in the laboratory.
And Dr. Nelson, are you able to share, actually a couple things, are there other sites that are open on this trial, or is it just at Children's National?
So right now it is just at Children's National, but we've been actively taking the steps to open at other sites as well. So including Children's Healthcare of Atlanta and Washington University in St. Louis. And so not open yet at other sites, but taking those steps to do that.
Yeah, and if patients do end up traveling to enroll, the expectation is that they would just need to be there for the infusions and obviously for the cryoablation, but like, I don't know, are there labs and all that stuff happening in between? Like, would you expect patients to actually have to kind of settle in for a few weeks, or are they able to just kind of be there for the infusions and
so during the first cycle, there are labs weekly. And so I know that's always kind of an addition of being a part of a clinical trial, that there's additional labs and check-ins that are needed. And so there is none of that aspect, and part is just to monitor the patient for tolerance and safety. So initially patients are expected to be around in the first cycle, especially, and then as we move further out, that there's a little bit more flexibility, and kind of later on that patients come in for their immunotherapy every 21 days, and then that changes to every 2 weeks. But the lab check-ins are less often, and once again, providing additional flexibility that you wouldn't necessarily need to be right in the area, but you'd want to be close by to, another hospital or care center that you'd be able to be seen if there were any issues or concerns.
Right. And can you share how many patients have enrolled to date?
So thus far, so we're actively screening patients. We have one patient thus far.
Okay, great. Do we have any other questions from the audience, or Walker? Do you have any other questions?
There's nothing that I can think of, and I think we got everything from the Q&A.
Okay, great. Well, thank you, Dr. Nelson. This has been really helpful and interesting, and I think also great for any patients considering this trial. This gives them a really nice overview. So appreciate it, and I think we can learn a lot. I mean, it's kind of interesting because obviously surgery, and we want to get those tumors out, right? Like that is kind of the first thing, but in a weird way, it doesn't have the benefit of this opportunity to stimulate immune response, which it seems like it could be an advantage just after MAP, right? Like just to kind of minimize chance of recurrence.
I think it provides an exciting option, something different. I think the mainstay of treatment still, if it's able to be resected for osteosarcoma, that's I think the best option still. But I think kind of after that, and based on limitations, for additional surgeries, that this really does offer an exciting option, and and potential an exciting option for potential response. And
yeah, no, I mean, it's for I mean, it seems like a great option for local control just because of, the minimal side effects, that it's outpatient, it's just a much kind of a easier treatment for the patient. But then you also have this potential of kind of systemic, effects from the therapy. So definitely some really positive advantages, hopefully, and hopefully we'll see that in the study results. So thank you so much for sharing with us today. Really appreciate it. And thank you for making it better for pediatric sarcoma patients everywhere. More information on this and all osteobites can be found on YouTube, on our website at mibagents.org, and also at your favorite podcast place. And for those of you who registered, we will send out links to all the recordings. And Dr. Nelson has been kind enough to also offer her slides to share with everyone. So we'll make sure we'll include those in our follow-up. And Osteobites is off next week, but we're going to be back Thursday, January 26th with Dr. Eunice Lopez Fuentes from UCSF. And Dr. Lopez Fuentes is one of our 2022 Outsmarting Osteosarcoma Because of Charlotte grant recipients, and she will be discussing her work on 2 epigenetically distinct cellular states in osteosarcoma that are regulated by a state-specific set of transcription factors driving differential drug response. And you can find our Osteobites lineup for the next few months on our website. If you have any ideas for future topics that you'd like to hear about, please share them with us at events@mibagents.org. And thank you again to Dr. Nelson and to Walker for spending an hour with us today. And thank everyone else for joining us today on Osteobites. We really are glad you are here. We hope to see you in a couple of weeks when we return with Dr. Lopez Fuentes on the 26th. So thank you, everyone. Thanks so much, Dr. Nelson.